thrombus burden in acute coronary syndrome. So we'll just get straight into it. The first case is an 84-year-old lady. She came in with a non-ST elevation MI. Her troponin high sensitivity was 9,600, so a real event. And this was her ECG. So for those of you that, just cast your eye over the ECG, nothing really sort of too exciting. Maybe some ST depression in the sort of lateral leads, but no obvious ST elevation or glaring evidence of ischemia. So she came to the cath lab, and this is what we saw. This was the LAD. And this was the circumflex. And you can start to see some of the PDA and posterior lateral branches of the circumflex kind of filling a bit late in that second angiogram. And then this was her right coronary angiogram. So I guess the question is, which would you treat? Would you treat the LAD? Would you treat the circumflex? Would you treat the RCA? Or would you stop and refer for CABG? And maybe I'll just say, we're interventionalists. We never stop and refer for CABG. So,
Yeah.
Bakas, which
Yeah.
vessel?
Are you getting my voice now?
Sorry?
Are you getting my voice now?
Yeah, we can hear you. Yeah.
Okay, that's perfect. It looks to be a acute coronary syndrome with like a non-ST initial MI. Obviously, this is very strange. According to ECG, the circumflex it looks to be a recent total occlusion, and LED is having a sequential year, multiple years starting from the proximal and mid and distal ports. So, to me, I will go with the PCI to circumflex at this stage, and we'll go for the whole vessel DCB for LED. For RC, I will just keep it conservative.
Yeah. I think that's not unreasonable. So you think the circumflex is the culprit?
It looks to be a recent total occlusion.
Yeah. What about you, Filippo? Or Sarah?
I agree with about the circumflex or as the culprit lesion.
Yeah. And Sarah, anything to add? Would you do the LAD, for example, or do you think we should do the LAD?
I agree with the others. The circumflex, I would say, is the main. Yeah.
So, I mean, I wasn't the operator, but the operator, for some reason, overnight decided to do the LAD. So they did the LAD, stent, and then drug-coated balloon to the mid to distal LAD. And you can see in the sort of distal segment there is some recoil, but they thought they had flow. The patient's pain had actually improved. And so the STs, I mean, there was an ST elevation. So they decided to leave it. And the patient went to coronary care unit on dual antiplatelet therapy. But 2 days later, he had more chest pain. They sort of tried to stabilize him for a day or so, but then he had more chest pain. And then I took him back to the cath lab. And the LAD stent was patent. The DCB segment looked the same. You can see that sort of recoil in the mid to distal, but the flow is still good. And the circumflex is occluded. So I thought, we need to open up this circumflex. So wired the circumflex was actually quite difficult to wire. So it's probably, I think, an acute on chronic. So had to go with an XTA and then with a microcatheter, used a compliant balloon, and this was the result we got. So you're starting to see some flow there. And so I thought, maybe there's a bit of microemboli or microclot. So let's try and aspirate a little bit. So we have access to the penumbra mechanical aspiration device. So this is looks like a guideliner. You just put it down. It's connected to almost like a suction machine, and it acts like a big vacuum cleaner. So you're just putting it there, and it's just sucking out all the clot as you drive it. So this is a mechanical aspiration pump, and it was shown in a trial to actually be more effective when compared to just the manual aspiration. It's a 5.3 French system. It's compatible in a 6 French device. But if you have 2 wires, a buddy wire, then you need to remove one of those wires. Really, it's quite straightforward. You load it onto your wire, put it to the position, turn it on, and then you just advance it for about 30 seconds, and then leave it on as you're removing. And then, you know, just like you would with any thrombus aspiration device. There are some considerations. So when you engage thrombus, sometimes you might not get any flow back. And that means it's kind of stuck on the thrombus and trying to actually aspirate. And so they say to wait for about 30 seconds. And then if you don't get flow, you start pulling back. But if you do get flow, then continue with your aspiration. So after the penumbra, this is what we got. And you're starting to see more of the vessel now. Still some thrombus in the proximal circumflex. So I decided to push ahead with a 2O balloon and then do a bit more aspiration. And, you know, getting some nice flow here. You can see where the lesion is. You can start to see where the branches are. So I guess the next question is, what would you do now? Would you do more balloon dilatation? Would you stop and stent now? Enough balloon, let's stent and secure this vessel. Or will you stop the procedure and defer the PCR? Maybe Jassim will ask you, I think, I don't know if you caught the images, the angiogram. Oh,
Sorry.
yeah.
I think I was here from the beginning of the interesting. We tend to use here in France, and the center that I've joined, not the same, not the continuous aspiration, but like they use the Godzilla with the system, with the normal aspiration system.
Yeah. So that works quite well.
There is a risk for yeah.
Yeah, so I guess in this situation,
Yeah,
what
there is a risk
now?
always with the because the continuous aspiration. Yeah, for me, I think for here it depends all on the thrombus charge. So if I have a lot of thrombus, I would do the Mimi strategy. I will put him on anticoagulation, take him back afterwards for stent or stent direct stenting. Those are my 2 options here.
Yeah, I think that's, you know, a very good point. So this is what you get after the aspiration. I think maybe a deferred strategy would have been good, some more anticoagulation, and you now have flow, the pain's resolved. But then I thought, you know, this is already his 2nd trip to the cath lab. We've already brought him. Maybe we just do a little bit more balloon and then secure it with a stent.
Okay.
And unfortunately, with the 3.5 balloon, we lost all the flow. And this is the big risk with, you know, the no reflow, particularly if you got a lot of thrombus that's a bit older. So again, now we have no reflow. You can see the dye hang up. So really just trying to aspirate, get the flow back. So after 1 round of aspiration, this is the flow that we got back. I then decided, okay, I need to go further down. So let me use a smaller device. So I used the Thrombuster device, went all the way down. I gave some IC adenosine. The patient was already on aspirin and ticagrelor and therapeutic heparin. So we checked the ACT to make sure. And this was the result after all of that. So still a bit slow, maybe TIMI2 flow, but we have flow. The vessel looks relatively patent. So I thought, okay, I'm not going to risk it and try and direct stent now because I'm worried that I lose flow again. So I'll stop. So I stopped, and like you said, Jassin, I put him on anticoagulation for 5 days. And this was the repeat angiogram.
Okay.
So you can see that the thrombus has all resolved. He does have some moderate disease there, but the flow is good. And so we just left it. You know, he's done well, so we left it. And these are the final results. We did an OCT just to make sure there wasn't any obvious, you know, large cavity or plaque rupture. And what you can also see is the DCB segment in the mid to distal LAD has already had an effect. Can you see there? It's either that or there was some spasm
Mm.
early.
Yeah.
But what you
Oh, yeah.
see is that mid to distal segment is looking so much better. So we left him and he's done really well. The second case is a 61-year-old gentleman.
Sorry,
a
Bharat.
Yeah.
Which anticoagulation
great.
regimen do you use?
Which, sorry?
Oral anticoagulation regimen do you use for 5 days?
So this one we used Clexane, low molecular weight heparin, in addition to aspirin and ticagrelor.
Thank
We
you.
felt he'd already been on ticagrelor for a few days. So the additional benefit of a 2B3A and platelet blocking, probably not as much compared to the anticoagulation effect of Clexane or heparin.
Yeah, I agree with you.
So the second case is this 61-year-old smoker with hypertension and high lipids. And he came in with a few hours of chest pain. And this was his ECG that he had done at the GP, which showed inferior ST elevation. And this was his angiogram. So the LAD, you can see there, looks horrible. The circumflex is okay. Left main to circumflex looks okay. But remember, this is inferior ST elevation. So you can see there is collaterals to the LAD, so suggesting chronicity to that LAD. He's got a lesion in the sort of mid RCA, still having TIMI3 flow. And because of his age, we thought, he might be a candidate for bypass surgery. So in this situation, the operator actually stopped and said, let's have some 2B3A. We'll refer him to the surgeons, and if they refuse, then we'll proceed with PCI. So what would you do now? Good flow in the RCA, leave it alone, or emergency PCI? How many of you would just push on and do PCI in this setting?
This is very tough decision at that time, because with the help of now you are having a penumbra device, but we think that if this device is effective for this slot in the RCA, because we don't have a penumbra device in our setup, we are having only export catheter.
Export or thrombuster, yeah. I mean,
Yeah,
you can
exactly.
see a large filling defect there. So I guess the operator was thinking, you put him on some 2B3A, clear the clot, then bring him back, and then you can do the PCI, safely. Because remember, this RCA is supplying 2 territories.
Exactly.
It's also supplying the LAD territory. So if you do get no reflow in this, he can become really quite unwell. So I think, a very a reasonably wise decision to stop. So put him on some 2B3A in addition to antiplatelets, and he came up to the ward. His echocardiogram showed an ejection fraction of 50, and he had LAD and RCA regional wall motion abnormality. But then a few hours after getting to CCU, he developed ventricular tachycardia, VT, and became hemodynamically compromised. So they asked him to take him back to the cath lab. So I brought him back. And this was the repeat angiogram. So much the same. Maybe the filling defect looks a little bit worse. So what would you do now? Would you continue with the same strategy as before? Or is your hand kind of forced now? It's the second time you brought him back. If you send him back to the ward and he has more VT and he becomes hemodynamically compromised, does it look really bad on you? So I guess maybe Filippo, what would you do now? Or do you just proceed and do the PCI?
Yeah, in my opinion, considering the frequent VT, it's reasonable to treat the RCA.
Yeah, I agree. I think, you've already had a trial of anticoagulation. He's had VT, and you probably need to do something a bit more definitive, whether you just do some thrombus aspiration to see if that actually can help dislodge, remove some of the clot burden, give the 2B. That's another way to, hopefully I get more direct effect. But we have a device, it's a Medtronic neuroradiology device. So we have access to this device called the Solitaire device. So it's a little stent-based scaffold where you can actually deploy it in the area of the clot, and it actually traps the clot like this. So it's a little basket that pulls out the clot. It's got its own introducer and a pusher, and you just push it out, and it will spring out and trap the clot, and then you just pull it back in and remove it, and this is what comes out. So we were involved in a clinical trial for this device by Medtronic, so we actually decided to use it on him, and you can see the clot burden is significantly reduced. No ballooning at all. No wire across the, you see there's no wire across the lesion. The wire is only there to deliver the device. You don't have to go across the lesion. So no real manipulation of the lesion. And we managed to significantly reduce the clot burden.
Actually, Bharat, sorry to interrupt you. This Solitaire, this is a retrievable stent we use in the neurointervention procedures.
Correct. Yes. For retrieving brain clots. You're right.
Yeah,
Absolutely.
exactly.
So it's
and
not
also we have, and also we tried with the Sophia catheter in one of our families as well. And Sophia also did very good job with this.
Yes. So a lot of the neuro intervention tools, actually, I think for thrombus can be quite useful. Sophia catheter, these sort of stent-based clot retrieval devices. So you can see there before Solitaire and after Solitaire, the whole thrombus section has cleared up. The plaque is still there. The area of concern is still there. So, what is Solitaire? It's a stent retriever. So a nitinol-based self-expanding, fully recoverable device. It's been used in acute ischemic stroke. Comes in various sizes. You kind of have to size it to the vessel. It does expand to the particular diameters. So in this vessel, a 4.0 vessel, using a 1.5 by 4.0 or 2.0 by 5.5 is pretty okay. There are multiple trials showing its safety and efficacy in acute ischemic stroke, and it is FDA and European approved. For us here in Singapore, it's HSA because of health authority approved. So we do use it for the stroke. But in the coronary, there is some limited studies. We have been involved in one. And really, there are some other devices like this from different companies. So these devices have been used in the coronaries. I think there's an Italian group that actually published this in Eurointervention in 2022, and really showing some good outcomes. And then we went on to do an OCT or OFDI of the actual vessel after removing the clot. So what you can see here is the vessel appears, really quite free of clot. You have that lesion segment there. So we just decided to DCB that and leave it. No, sorry, we ended up putting a stent there because there was evidence of plaque rupture. Initially, we thought we were going to DCB, but because of the degree of the plaque rupture and the depth of the dissection down into the sort of media, we thought it's best to secure it with the stent. So a single 18mm drug-eluting stent, and the vessel looks okay. There is some more proximal disease, but it was moderate, more than 5 on OFDI, so we decided to leave it. So he was well. He actually went to see the surgeon, and they did a minimally invasive Lima to LAD, and he's been really well with preserved ejection fraction now. So the final case before we finish, this is a 69-year-old male who came in also with a non-ST elevation MI. His troponin was 7,518, and this was his ECG. So his angiogram showed this, the right coronary artery. You can see there's minimal flow, and it's a big artery with a bucket load of clot sitting right in that sort of proximal segment. So wired it, and you can see even after wiring, the vessel's very, very big, and we're not really getting flow. Big amount of clot there. So decided to do the penumbra again, just to try and remove as much clot as possible. Again, you can see the flow is really sluggish, still have a lot of clot down there. And tried with an export right down to the bottom, more 2.5 compliant balloons. So now you're getting desperate, you're trying to just get flow and try and reestablish flow the best you can, because one of the things that I've realized is with these patients, if you want to stop and put them on anticoagulation, you need distal outflow, because the thrombus is not going to dissolve if your distal outflow is poor. So you tend to try and get some distal outflow, then you can put them on a few days of anticoagulation and come back. So what I did here was to administer intracoronary lytic. So I used a fine cross microcatheter, a Corsair Pro microcatheter, and then a 4-0 balloon, and gently inflated the 4 balloon to occlude the vessel proximally, so no new blood comes in. And then through the microcatheter, I gave 10 mg of RTPA. 10 micrograms of RTPA. So 1/10 of the systemic thrombolysis dose. So 1/10 of the systemic thrombolysis dose given through the microcatheter, and then leave the balloon up to allow the thrombolytic to mix with the blood there and hopefully dissolve everything before you flush new blood in. So you can see before lytic on the left and after lytic. And this is the flow we get after lytic. So still a lot of thrombus, but you can kind of see the PLV is there. You got the PDA, and you're starting to see some outflow. So just with a single dose of intracoronary lytic, we managed to get flow back. So then I decided, okay, let's go a bit more distally. So I put the 4-0 balloon a bit more distal, inflated, and gave a second dose. And this is the sort of final result after RTPA. The PDAs come back, the PLV, not completely resolved, but it's looking a lot better. And I think now I decided to stop and put him on 4 days of anticoagulation, and this is how we came back. So I thought we'll bring him back and we'll have a re-look, and you can see the whole vessel has sort of come back to life.
Yeah,
so some take-home messages. High thrombus burden in PCI remains challenging. It can often lead to distal embolization and no reflow. There are some tools that we can consider using. Your standard manual aspiration thrombectomy, and like Jaseen said, you can use a guidezilla or a guide extension catheter and put the aspiration syringe on it and aspirate. You can use mechanical thrombectomy, and for us, we have access to the stent retrievers. And don't forget pharmacotherapy. I think, we always want to try and fix things, but if you can hold off, you get flow, you put them on anticoagulation and bring them back, when it's much safer, the thrombus is all gone, the risk of no reflow is much lower, things have cooled down, they've been on high dose of statin for a few days. So always load with antiplatelets, make sure your ACT is appropriate, consider 2B3A inhibitors, and you can also consider the use of intracoronary lytics. Consider deferred stenting like we talked about after achieving flow. And sometimes you might have to use not just one device or technique, but multiple to achieve adequate reperfusion. And just remember to be patient and persevere. Thanks very much.
Thank you very much, Dr. Bahar. They're very, very interesting 3 cases and very deductive. I learned a lot. Thank you.
Yeah, no problem. I thought, a bit more kind of clinically relevant and kind of introducing some of the devices that we use in our practice. I mean, we get a lot of ACS where I work, some, delayed presentation. So we do have patients with a lot of clot burden. So we're quite fortunate we have access to some of these devices, and yeah, just thought I'll share some of these cases with all of you.
Quickly, I have one question more. How much time you will wait for after giving the TPA in the coronary? You have to wait for 10 minutes or 5 minutes to the lab and then see the results or immediately.
Yeah, so for me, what I've started to do now is to use that blocking balloon technique, and I leave it up for about 4 to 5 minutes. I feel the problem is if you leave it up too long, they can get quite ischemic. So it depends on, you know, how bad the vessel, how long the vessel's been blocked for. You probably can't leave it up for too long as well because they can get ischemic. But before
Yeah.
giving doses, I would wait about 8 to 10 minutes, check angiogram, and then give another dose if you need to, and then wait again. I probably usually stop at 2, one more proximal, one more distal. And I find by using this blocking balloon technique, it's become a lot more effective because what's happened is the thrombolysis stays there. There's no blood coming to wash it out.
Yeah.
You see, you're preventing new blood from coming and washing it and diluting it. So you have the full effect of the thrombolytic in that area.
Okay.
Then what you do is when you release it, it washes out all the, you know, all the dissolved clot, the smaller bits. So I think that's been really helpful when I've done it. When I've just given it either through the guide or through the microcatheter, it hasn't been as effective because I think blood just gushes in and dilutes it. So then you're using 1/10 dilution of the thrombolysis with blood coming in, you know, fresh blood coming in with every cardiac cycle. It's diluting it even further. So this technique I find works quite nicely.
Okay.
Yeah. Any other questions?
Can we use the thrombolysis, intracoronary thrombolysis with the patients who received ticagrelor? Or I don't know,
So
like
yeah,
because-
these patients, you know, these patients, most of the time, for our ST elevation patients, they all get loaded in A&E with
Yeah.
ticagrelor. Most of the time, by the time you're seeing them, it's kind of 60 minutes, 90 minutes, you know, from when they've ingested. Not all the ticagrelor has had an effect yet. So I mean, these patients, we're giving them after they've had aspirin, ticagrelor, heparin, sometimes 2B3A. And that's why we don't use the full dose. We just use the 1/10 kind of boluses. So there's
Yes,
always
I got you.
theoretical risk of having, you know, bleeding. But we haven't seen it yet because we give the boluses of the 1/10 dose. And it's very localized delivery through the microcatheter with the blocking balloon.
Okay.
So you get very little kind of systemic effect. You get a direct effect on the thrombus, and then with the blood coming through, it kind of dilutes it and washes it away. Yeah, so we have done it a lot of times on patients on ticagrelor because that's what, you know, the patients that we see, they all get loaded in A&E with ticagrelor.
Okay.
And also, if after giving TPA during the procedure, and you are just buffing the patient for next 24 hours for anticoagulant next 3 to 4 days, are you giving any glycoprotein to any individuals for next 18 hours or 24 hours along with this?
Yeah, that's a good question. I mean, we get really worried about that because if you've given thrombolysis, I mean, theoretically it's short acting, but you know, I am very scared because I've seen patients have catastrophic thrombocytopenia. I've seen them have spontaneous bleed on 2B3A infusions. So if I do give it, I tend to give a slightly lower dose. So rather than we use integralin. So rather than giving the standard dose of 2 mics per kilogram per hour, I give 1 mic for 18 hours with aspirin, with ticagrelor. And then after 18 hours, I switch to Clexane or heparin, whichever, you know, whichever. And then I tend to continue heparin at least for 72 hours. I find like if you bring them back too soon, the clot usually hasn't had time to dissolve, particularly if you've had so much clot. So I tend to wait at least 72 hours. Sometimes, you know, if they come in on a Thursday, we'll wait till Monday to do the relook angiogram so that we can send them home, you know, Monday evening or Tuesday morning.
Okay.
But I tend to wait at least 48, 72 hours before relooking. Otherwise, you just relook too soon, and it just looks, you know, usually looks the same or maybe slightly better. Then you're like, you know, what do I do now? Do I fix it now? But you want the clot to clear, because if you do some imaging, then you want to see clearly. You don't want clot sitting in where the plaque rupture was. Then you can't really make out the borders. You can't really decide whether you need to stent it or you can leave it. Hours of or chest pain or ST elevation or something like that. So I think it, I think, you know, that would be the only time I would go back earlier, but most of the time, usually 4 days. Yeah.
Excellent.
Okay, good. Thank you. I hope it was interesting, and tried to keep it kind of succinct and you know, and just to the point. But yeah, hopefully that helps, and thank you for
Yeah,
your
perfect.
attention.
That's
Yeah, thank
Thank
you
you.
very
Thank
much.
you very much.
Thank you very much. It was great.
Problem.
Thank
Nice
you.
to see you all. Take care.
Thank you. Bye bye.
Bye.
Thank you. Thank you.